Welcome to Community Conversations. My name is Luke Margolis. I'm the Corporate Communications Director here at Atlantic Health System. And today I would like to welcome back for his second community conversation, Dr. Jason Kessler. He is the Section Chief of Infectious Disease at Atlantic Health System's Morristown Medical Center. Dr. Kessler, welcome back.
Thank you, Luke. I'm glad to be back.
Yeah, we didn't scare you away last time, so you're back for another one. Before we jump into our conversation, I'll give our folks who may be joining us for the first time a little bit of background as to how this works. Dr. Kessler and I will chat for a little bit. We will try to incorporate some questions from our audience, and of course, if you have anything you want to add as we go along, please feel free to add that into the comment thread alongside the video. We'll try to loop in some of those comments as we move along as well. This will be seen as you are now live on Facebook. However, we are also sharing it in some other platforms. Go to our website, atlantichealth.org, and you'll see a link to all of our community conversations there. You can find it through our various social media accounts, including LinkedIn. And for those of you who are more comfortable watching on television, News 12 Plus airs us on weekends, 8:30 to 9 on Saturdays and Sundays. So that's kind of the gist of how we do this process. And Dr. Kessler, like I said, welcome back. The topic, or the title, I should say, of this is basically what you need to know now about coronavirus. And so what we wanted to do was acknowledging the fact that you and I last spoke in this format, I think it was the second week of April, right around April 16th or the third week of April, somewhere around there. But a lot has happened between now and that point. And so I want to start first with a question of just as we reflect back on what we knew then versus what we know now, how much in your opinion has changed? Do you think we got a lot of this stuff in terms of our knowledge of COVID-19 right early on, or how much have we learned in a broad sense, and then we'll drill down? What do you think?
Yeah. So I think that the big message that I would like folks to take away from today's conversation is that we are still learning a lot about COVID-19. We have just started the learning process.
Wow.
A lot of what we were doing, saying, recommending 4 to 6 to 8 to 10 weeks ago, we're now saying slightly different things, or maybe even completely 180 degrees the opposite thing of what we were saying at that time. So the process of science and the process of medicine and the process of clinical care and epidemiology and public health is a process that is constantly undergoing iteration, constantly undergoing change. And that's a good thing and a bad thing in some cases, because sometimes that can create confusion because one thing that we say today may not necessarily hold true tomorrow as the science changes and as facts evolve. And as the truth comes to light, so to speak. And I think that's the big message, is that we're still learning. We are going to make mistakes, and we are going to say things that we're going to have to backtrack on somewhat, so to speak. But all of that being said, we are trying to use, both at Atlantic Health and I think across the country and across the world, the best methods available to us, and trying to expand our knowledge base as quickly and as efficiently as we can.
Let's start with some of the public health initiatives. I think that, and they are things that we continue to talk about now, so I've probably answered my own question to an extent, but I think it's worth reinforcing. Those early public health things, that guidance that we provided for folks, the masking, the hand washing, things along those lines. In your opinion, are those tactics still as relevant today as they were?
Yes. I think the public health messaging and the public health measures that we've put into place at least since early April are still very relevant and are still critically the most important things that we can do as individuals, as community members, as citizens to prevent and mitigate the spread and impact of COVID-19. And they really come down to a few things. Keeping social distancing in place, right, whether you're indoors or out of doors, washing your hands regularly, keeping very close attention to your cough hygiene, so coughing into your sleeve or a tissue. And now we've really included, since we last spoke, the benefits of wearing masks or facial coverings.
In fact, when you and I last chatted, this was actually before the universal masking concept had really become as widespread as it was. So that very much is a newer concept.
Yeah, and I think that there is a growing body of evidence that mask wearing by the general public, as well as healthcare workers, which we had always been doing, may have a significant impact on reducing the spread of coronavirus. It's not going to reduce it to zero. Masks are not a magic bullet in any sense, and the evidence is not definitive or conclusive, but I think that there's plenty of evidence on a population level, on a basic science level, that there may be some impact, even for the public, to wear simple cloth facial coverings. And not all coverings are the same, and not all masks are the same. There's a gradation of benefit and a gradation of utility. And they range from, the medical respirators that doctors and nurses and other staff members use in the hospital, the N95s,
yep, things like that.
and they range all the way down to something like a simple cloth covering.
Sort of like what we have.
Yeah, and so they're not all the same, and I think everyone recognizes that. And some offer a greater degree of protection to both the wearer and to the public around the wearer. But I think that there is a growing body of evidence that, masking can reduce the spread of COVID-19, and that is a change, a very significant change from what we were saying at the very earliest parts of the epidemic.
What about in terms of how we are caring for those who have, and I know this is tied into another discussion that I want to have today as well, about changing numbers and figures and things that we're seeing in other parts of the country and how they relate to what we have here, but how about how we are caring for those? What have we learned about the virus and the way we care for people now that is different from where we were in the early stages of this?
Yeah. Well, I think we've learned a tremendous amount in the area of therapeutics and the area of clinical care of patients with COVID-19 as well. What we were doing in the hospital, and even out of the hospital, 10, 12 weeks ago is vastly different than what we're doing now. Nowadays, you have a patient that comes into the hospital, they are being managed in a completely different, almost in a completely different way in some respects. They're getting different kinds of medications than they were 12 weeks ago. They may be getting different sorts of additional therapeutics or different kinds of supportive care than they would be potentially 12
Proning was
weeks
something
ago.
I heard. More patients are now being put on their stomach, actually.
Right. So things like proning, different types of strategies to use the mechanical ventilators if and when patients develop critical illness. And in particular, some of the medications, I think there's been a lot of attention paid to that, but some of the medications that people have been using or were using and continue to use have changed quite dramatically over the span of the last 12 weeks.
How is that reflective of how infectious diseases are learned about and managed, period? COVID-19 is not the first infectious disease that we as a country, as a planet, have faced. So are there similarities with how this process has moved for us as with other things? And maybe for some folks out there wondering if there will ever be an end to this type of effort, maybe there is a positive there in how this ideation has moved forward.
Yeah, I think it's very similar. Obviously, there's dramatic differences, but overall, if you look at a very high-level view, the response to the COVID epidemic and the manner in which we've learned about it and responded to it is very similar to the manner in which we've learned about and responded to other serious epidemics like the H1N1 epidemic in 2009, the West African Ebola outbreak in 2014 into 2015. In both of those cases, for example, we learned a great deal, whereas initially we didn't know what really would work, and we tried, to learn as quickly as we could. By the end, or at some point after that, we had both a vaccine as well as novel therapeutics and a care strategy that actually saved lives. So I see the response to COVID-19 in a very similar light as I see our response, our global response to some of these other pathogens of concern that were on everybody's mind not too long ago.
We have talked as a system, and I know that some of our leaders have talked about this in various media interviews and things along those lines, but we talk about the peak of cases that we had here as a system, as a state, really, in that second to third week of April area. We are a far cry from that now. But as we see some of what's happening in other states in recent times, I think there is a lot of renewed interest in how we are measuring the spread of the virus and what's happening here, in the hopes that we don't then fall back into where some of those states are. I have seen recently that the the spread of the disease being measured in with a 1.1 number, 1.03 number. I've seen a couple of different things over the last couple of days. Can you explain for folks who may be seeing that same information out of Trenton, out of the governor's office, and are having a hard time interpreting what that means relative to the facts on the ground? How do you measure the spread of an infectious disease like this, and what does that number mean, that 1 point whatever it may be?
So we as epidemiologists, I was trained as an epidemiologist in addition to as a infectious disease physician. We use two main descriptors to describe the transmission of a communicable disease like COVID-19. One is the reproductive number, which I think people are aware of or have heard of. It's the R0 or R0. And basically what that number refers to is the number of secondary infections that an individual usually will pass on.
So them plus whoever gets it from them.
Exactly. And usually the classical thinking is if that number is 2 or greater, there's going to be continued epidemic spread within a community. So if I have COVID-19, for instance, and the R0 in the community or at the time is 2 or greater, I'm going to spread it to at least 2 other people. And I think that the studies that were done early on in the epidemic suggested that there's variation, but the R0 or the R0 for COVID was certainly greater than 2. Mm-hmm. But for example, as a contrast, something like measles, which is one of the most transmissible diseases, may have in some cases an R0 greater than 10. So
okay, so relatively speaking, it's a far cry from that.
Exactly. But the interesting thing about the reproductive number is that it is dynamic, meaning it changes. And it changes in response to human activity, it changes in response to human behavior, and it changes in response to interventions that we may put into place. So if we put into place a social distancing policy or practice, and it's widespread, the R0 will decrease. Similarly, if we have
I was going to say, what gets it to go up?
Yeah, if we decide that we're not going to do that anymore for whatever reason, and people go back to doing the things that they were doing in December or November of 2019, the R0 will go back up again. So the R0, the reproductive number, is dependent both on the virus itself or the pathogen itself, its characteristics and how it behaves, but it's also in large part determined by what we do in response to it. The other number that's thrown around some in the lay press, but many people may not be as familiar with it, is the dispersion factor. And that really gets at the issue that not everyone transmits the virus equally. There are some people who seem to transmit it much more widespread, the quote-unquote super spreaders, okay. And there are other people that don't seem to transmit it at all or very little.
Do we know why that is? Why some individuals may spread it more than others?
Yeah, I think it has some to do with the person, and it has some maybe to do with the virus, but probably it has the most to do with the setting and the situation and the behavior of the individual. So if you have somebody who's in the earliest phases of their illness, they are not practicing social distancing, they are not practicing good hand hygiene, and they're not practicing face coverings, and they go to an indoor setting like a concert or a sporting event where there are other susceptible people, that has a high chance that there's going to be a lot of people infected, and that's going to have a high dispersion number. Whereas if you took the same person at the same stage in their illness, but instead they were wearing a mask, they weren't going to an indoor crowded activity, they were outside just with their family, maybe nobody gets the infection from that individual. So I think a lot of it has to do with the context and the setting that you find yourself in and where you are in the illness.
I want to mix in a couple questions that we've gotten from folks because again, we want to thank everybody who took some time to send in some questions for us. Doctor, if you will, we've got a couple that all kind of fall into a similar sort of zone, and they're topics we've talked about in the past, so I want to take this opportunity to refresh our knowledge and see where we are on them. And Carla has emailed us wondering, as a as a grandparent who maybe has not seen their grandchild in quite some time, is it now safe to do so? And maybe that's more of a question that requires less of a physiological answer and more of a behavioral one. But in your opinion, under what circumstances is it safe for grandparents to see their grandkids again?
Well, I think every case is different. It's hard to make a one-size-fits-all kind of policy or recommendation for a question like that when it comes to an individual's risk of anything, of driving in a car or taking an airplane or crossing the street or visiting your grandchildren when the COVID epidemic is present. But I think the things that should go into one's consideration are, have you or your family been following and complying with the recommendations of the jurisdiction in which you live? Usually that means social distancing and not going to indoor crowded events or areas. Mm-hmm. Are you, as an older person, particularly susceptible to COVID-19? If you got infected, would you be at high risk for a very poor outcome? Now, obviously, age is the greatest predictor for bad outcomes in COVID-19, but not all 70-year-olds or 80-year-olds or 90-year-olds are the same. I've seen some 90-year-olds in the hospital. I'm like, they look like they're 75, if not 60.
You should all be so lucky, I guess.
But then again, there are others that, younger people who have very significant and serious medical conditions that would put them at very high risk for a bad outcome. So these all need to be balanced together when making a decision like that. But I think that in general, again, this is a general comment, where we find ourselves currently, so we're talking about the Northeast, the metropolitan area, we right now are in a situation where we have fairly low community spread, nothing compared to right now what's going on in other parts of the country. Right. And as such, I think that the risks are certainly lower than they were 12 weeks ago. And so if you're a grandparent or you're a parent of a child who wants to see their grandparent and you're healthy, and you've been following the precautions and you've been socially distancing, and your grandmother or grandfather is generally a well person and is has severe chronic medical conditions, then I do think as long as people are following the social distancing recommendations and the masking recommendations, then it is okay to visit with their family, and they should, because psychological well-being, both for young people, Carla, as well as the grandparents themselves, is important. And so, I with care and with thoughtfulness, I think it is appropriate.
Susan is going to have spinal surgery soon, and she wants to know, should she be wearing a mask when she's in the hospital, and will healthcare workers be wearing masks as well? What can we tell Susan about the way we're delivering care
Sure.
right now during what's going on?
So I think that is one of the very interesting but unfortunate secondary effects of the COVID-19 epidemic, both in New Jersey and New York and in our area, as well as other parts of the country, in that people delayed the care that they needed. Some of it was rightly so, and some of it was because they were scared. Right. And we've learned a tremendous amount about how to keep people safe while taking care of them in the hospital. And so at Atlantic Health, and I know in other hospital systems around the country, many different procedures have been put into place to ensure that people are cared for safely. So for instance, I can speak knowledgeably about our system in our hospital. What we do, patients who are coming in for procedures or for surgeries, they're going to be tested for COVID-19 to make sure that they don't have asymptomatic infection, because we know that patients who have COVID-19 compared to patients who do not have COVID-19 have poorer surgical outcomes. So we don't want to be doing non-emergent surgery on a patient who has COVID-19. We'd like to delay it if we can. Sometimes that's not possible. Sometimes they're having a heart attack, or they had a severe trauma, and they absolutely must have the procedure. They absolutely must get care at that moment. What do we do about those folks? Well, our healthcare workforce has a standard universal masking policy in the hospital. So all of our healthcare workers are wearing masks. All of our healthcare workers have been instructed in appropriate hand hygiene. And so they are looking out for the best interests of our patients. And any patients that remain in our hospitals who do have COVID-19 are geographically separated from any patient that's coming into the hospital for another reason. So the chances of cross-contamination are extremely, extremely small.
Thank you, Doctor. And thank you, Susan, for submitting that question. Ryan has a question on Facebook. Can you, in terms of the age groups, in relation to people being carriers and how they're impacted, how this affects people differently, you talked a little bit about age being a precursor for how you deal with COVID. What are we seeing in terms of various age groups? Let's start with our younger folks who were very much in the news lately, at least as far as the spread of this, but let's start with our younger folks and then move our way up. How are we now, what do we now know about how COVID is contracted by those folks and how it affects them?
Well, I think there's still a lot of information that we need to learn about how it affects especially the youngest of our population.
Like school-age kids.
School-age kids. I think we don't really know exactly what the differences are between school-age children and older children or older adults, and how they are infected or not infected, or how susceptible they may be or not susceptible they may be. I think, you know, for children, generally speaking, they tend to have less severe disease. They're at much lower risk of severe outcomes like death or severe morbidity than older folks. I think that's pretty clear based on our experience. But young people can die in very rare cases of COVID-19. So it is not something that we should be taking lightly. So it still can affect anyone severely, though it's certainly much less likely in certain cases. You know, I think what we've seen, you know, during our experience during the first outbreak or first surge was, you know, there was a lot of attention and focus, rightly so, paid on the older populations, and those were the people that were really suffering the greatest morbidity and mortality. But if we look back at the global picture, in New York and in New Jersey, the places that were really first hit hardest by COVID-19, the majority of people who were diagnosed with COVID-19 were under the age of 50. So young people contracted at least an equal, if not greater rate than older folks. And the reason that is because the young people are the ones, when I say young, I don't know if I can include myself anymore in that, but
for argument's sake, why not?
Young people are the ones that are out in the communities, they're working, they're in closed offices, they're interacting socially, so they're at much higher risk for that reason. When you look at the people who suffered the most, who had the most severe outcomes of COVID-19, that is when you start talking about the people who are living in nursing homes, people who have very severe chronic medical conditions, people who are older. But what we're seeing now in the vast majority, or other regions of the country that are now experiencing what we experienced 3 months ago, or 2 to 3 months ago, is not that different. I mean, in Florida, for instance, or in Texas or Arizona, the vast majority, or at least a majority of people that are contracting COVID-19 are people under the age of 50.
Brian wants to know, and I think you actually gave the answer to this a short while ago, so let's repeat it for Brian so we can. The separation of patients when they're being treated, those with COVID and those without, that is something we are doing at our facilities here at Atlantic Health System, yes?
Correct. That is something that we instituted very, very early on. It was probably one of the key interventions that our leadership implemented that was tremendously successful in reducing the potential spread within a healthcare facility. And we continue to do that, and we will continue to do that moving forward.
So Brian, there you are. Molly wants to know, and this is the answer, this is the question that is so difficult to predict, and you know, and so I think everybody will understand if we're not able to put too fine a point on it, but it's the question on everybody's lips in New Jersey at least. Molly wants to know, what are the chances for a second wave of COVID-19 here in New Jersey? And New Jersey specifically, but just a second wave.
Sure.
What are your thoughts?
I mean, I think the bottom line is I would be surprised, very surprised, if we don't have some increase in our incidence of COVID-19 in some point before a vaccine becomes available to us. Well, I don't believe it's going to look exactly like what we experienced over the last 3 months. I think it's going to be somewhat different. in its scope and its intensity, but I do think we should be expecting to see, an increased caseload in New Jersey in some points.
Some of that's up to us, though, right? I mean, I think there is a bit of, whereas in the beginning, maybe I don't think everybody fully knew enough to say that that was in our hands completely. We know that for the most part now, right?
Exactly, and I think that's why it's going to be different as far as the number of cases and the intensity of the cases. I think we're doing a lot of things differently than we were in the beginning of March. Most people are socially distancing. Most people are washing their hands regularly or paying much more attention than they were in March to things of that nature. And I think most people, generally speaking, are wearing masks when they can't socially distance. So all of those things are very, very different to our behaviors or the way we were acting and conducting ourselves, in early March and mid-March when this all really started in our area anyway. So I do think it's going to change what we see should we start seeing an increased transmission in our community again.
Daphne wants to know, and this harkens back to this idea of being in an indoor facility versus an outdoor space. If we know that particulate respiratory droplets, things along those lines, are a main method of transmission here, can you talk about what the implications are when you are inside versus outside? Is it just that much harder for respiratory droplets and things of that nature to transmit to another person when you're outside? What is it about inside and outside that makes such a big difference?
Well, I mean, I think it's it's very complicated, and I'm not.
Yeah, we don't need to dive too deep into molecular biology.
I'm not an expert in airflow dynamics. I mean, there are people who spend their entire lives dissecting and trying to understand the dynamics and physics of airflow within buildings and in the outdoor setting. But you can imagine, in very simplistic terms, if you put an amount of virus in a contained space, the concentration of that virus is going to be greater than if you put it in a much, much larger space, like outside. And the wind patterns that are outside tend to disperse those particles around an individual much quicker than interior or inside, where the airflow may be much more constrictive or restrictive. So I think that has a lot to do with why indoor transmission is so much more, or so much bigger of a challenge to get our hands around compared to outdoor activities. And I think that bears out in that we haven't seen large super spreader events stemming from outdoor activities or that were clearly associated with outdoor activities. Sometimes it can be because there are situations where people aren't socially distancing and are maintaining very close space even in the outside setting. And so there is still a potential for transmission, but I do think it is much reduced.
We have time for one more, and I want to ask you something that I think is impactful because it's very reflective of where we were versus where we are now. There has been a precipitous drop in many cases in, I guess, what some folks are calling the mortality of the disease, the death rate of the disease. And I think it has led some to believe that perhaps COVID-19 is just either not as dangerous as it was, or maybe losing steam in some way. Can you articulate for everybody, I guess in a broad sense, is COVID-19 still very much a dangerous, deadly condition? And if so, what is it that is causing the death rate to drop? If I'm articulating this properly, and if I'm not, please correct me.
Yeah, no, I think that a lot of people have that question on their minds, and it seems counterintuitive compared to what we saw early on in the epidemic. And what I can tell you is that COVID-19, SARS-CoV-2, the virus that causes COVID-19, is still a very serious virus, and COVID-19 is still a very serious illness. Again, in the majority of individuals who are infected, they're going to recover, and they are not going to be hospitalized, they are not going to be in the ICU, and they are not going to be on a ventilator. However, SARS-CoV-2, COVID-19 is a very transmissible infection, meaning you can give it to a lot of people in a very short span of time. And we have a highly susceptible population. The studies that are now being done suggest that in large metropolitan areas that experienced the first wave, maybe 9 to 10% of the total population was infected. That means that 90 to 95% of us are still potentially susceptible to getting this.
Right.
And if you take the population of New York or New Jersey or the United States, for instance, and just say, well, the death rate's only 1%, or even less than 1%. Well, 1% of 300 million is a lot of people.
Yeah.
So you take a small percentage of a big number, you're going to get a big number. And so it's still a very big concern, and I think people really do need to take it very, very seriously and continue to take it seriously. That being said, I think there are several explanations as to why the case fatality rate continues to either stay stable or decrease compared to what we saw. And I think that has to do a lot with all of the behaviors and interventions that we have put into place. We know, and people know, the most highly susceptible individuals are older people with chronic medical conditions. And I think if you asked the average older person with a chronic medical condition, what are you doing now compared to what you were doing February 1st, 2020, I would imagine the answer to that question is remarkably different.
Sure.
So the people who are most susceptible are aware, for the most part, that they are the most susceptible, and they are taking, I would imagine, generally speaking, every precaution that they can to prevent them from getting it. And what we're seeing now is that, younger folks who tend to have a little bit of magical thinking, that nothing can hurt them, and that may be true to some extent, but we're seeing many more of them get infected because they may not be complying as rigorously with some of the precautions that are recommended. So we're seeing cases increase, we're seeing case fatalities sort of stay the same or even decrease in some parts of the country. And I think, again, that has a lot to do with what people are doing and their perception of their own risk. But the point is that even if you're young and you think you're healthy, there are young, healthy people who have died of this disease. Maybe it's not tens of thousands of them, but there are cases. And there are simple things that you can do to prevent the spread of this disease and to protect yourself.
And those are amplified by the fact that we now know so much more than we did before. So Dr. Kessler, again, thank you for coming back and for joining us again for this conversation. I know there are a couple questions rather, that we were not able to get to through our conversation here, but we will try to get you answers through our social media platforms. And of course, please feel free to reach out to us if you have any additional ones. So for Dr. Kessler and for myself, thank you so much for joining us on our community conversation, and we will see you next time.